in pediatric nutrition, and we are going to start by talking about learning objectives. As you can see in this slide, we have three areas from where our objectives are. The first one is around prevalence and consequences of pediatric obesity. The second one is around etiology and prevention of pediatric obesity. And the third area is around dietary and lifestyle management of pediatric obesity. For each of those, we have objectives such as assessment of pediatric obesity, discuss prevalence and health implication. We will be learning and discussing about early influences of pediatric obesity as well as preventive strategies. And finally, management around diet and behaviors, as well as recommendations for childhood obesity. We will now move on to discuss prevalence and consequences of pediatric obesity. The first slide that you can see is discussing the rising of prevalence and the crisis in childhood obesity. First of all, I would like to share with you that the definitions of obesity are all over the map. We are here discussing about WHO, UNICEF, and World Bank Group, which is the old IOTF, who are aligning together to provide some numbers for children under 5 years of age. And you can see that we're talking millions of kids across the world, with an increase that's expected to about 70 million in 2025. If now we focus on the definition from UNICEF, and I would say for everything you read, look at what anthropometric parameter people are using and what is the cutoff point. In this case, the graph that you see is using weight for height above the 2 standard deviation. And using this cutoff point, you can see that worldwide, you have about 6% of children under 5 who have a problem of weight. And this can go up to 16% in the European countries. However, we know that countries in transitions have a very fast increase, about 30% more recently. And you will see also that numbers, for example, in the USA are really high. Without waiting, I would like to discuss more about assessment of pediatric obesity. First of all, I would like to tell you that most people, as an entry in a program, are using, or in healthcare, are using body mass index. But beware, body mass index is not an assessment tool, it's a screening tool. The reason is that first, it's a great tool in the sense that it's easy to measure weight, easy to measure height in a clinical setting, and divide them to obtain body mass index. However, body composition varies with age, ethnicity, varies with gender or sex, and also with pubertal stage. So it's a very broad estimate, and you need to evaluate other things, such do an exam, such as do some labs, and also evaluate behavior and dietary intake. What I would like to tell you is that there are multiple growth standards. The most commonly used are the WHO growth standard, the CDC growth standard, and the World Obesity Federation standard. However, the population survey underlying those standards are different. And the cutoff points used are different too. So for example, WHO, they're using for children who are above 5 years, data from NHANES, which is CDC, from the 1970s. For those kids who are less than 5 years old, they have a wonderful multi-country study that is available. In terms of the World Obesity Federation, what they have done is also multiple countries representative, and they have used, very interestingly, the maximum cutoff point for the adult and then provided lines to reach those. So they have adjusted the lines for cutoff points across the ages. So very complicated. Always read when you read the literature or when you decide to use a standard in your clinic. Make sure that you use the right nomenclature and that all your staff and patient know about the references you are using. The next slide is an example of an algorithm for assessing childhood obesity above 2 years of age. Different groups do it differently. This is an example in one of the hospitals in the US. There are 3 areas of work. The first is you want to see what the weight category is, and we're going to discuss a little bit about this. Assessing behaviors, so diets, sedentarity, and eating behaviors, and then provide some counseling. Everybody should be providing ambulatory prevention counseling, which is also called anticipatory guidance. And for those who start having a problem with too much weight gain, you can then focus more on a counseling that's a treatment approach based. And so in terms of categories of weight, you can subdivide it as healthy weight, overweight, or obese. And you can see here we're talking percentile because that's what we're using in the US. If you are using WHO criteria, you would be using Z-scores. So once you have identified a problem, you're going to get a family history, you're going to try to review your systems, do a physical exam, see if there's any concerns about that and new vitals, and then you're going to decide if there is no risk factors and you're going to give routine care for a healthy patient, or if the patient is overweight, you're going to decide, okay, are there risk factors? There's no risk factors. If they are, or the patient is obese, you're going to do laboratory screening and then look for obesity-related conditions. There is no accepted guidelines for screening tests, such as blood tests. However, there are some consensus by different societies, and they vary. I will tell you that overall, the American Academy of Pediatrics, they're focusing on fasting glucose as well as fasting lipid profile, ALT and AST to evaluate for fatty liver. The American Diabetes Association likes to have an hemoglobin A1C, which might be very useful for monitoring because by the time the glucose is high, the child is in jeopardy, while you can follow the A1C and provide a really very good focused recommendation for the family. So it varies a little bit from one place to the other, and hopefully we will have some consensus and some evidence-based practice in the future. In terms of health implication, there are multiple. They're not only in adults, there are in children too. To take a few examples, in this slide, the child can have dyslipidemia with high triglycerides, for example, and a low HDL. We see some kids with type 2 diabetes, they're already 8 years of age, or fatty liver with increased ALT, but that has to be monitored and repeated, and you need to do imaging to identify the problem. Those children tend to have early puberty, but some of them are too early, and you have to investigate why. Who gain weight really dramatically in the beginning, and their height is very elevated. What you need to also know is that there are studies that have shown that at the end, they will reach their parental potential, and those studies come from Europe, cohort studies. There are an array of orthopedic conditions that can happen. Some of them are considered urgent. Within 1 or 2 days, you need to intervene in the operating room for a child with sleep capita femoral epiphysis. Also, pseudotumor cerebri, it's an acute condition where you have too much fluid that builds around your brain. To move on, I would like to discuss further in the next slide a few of the implications in adults. Those are better known, I believe. There are joint problems, there's type 2 diabetes, kidney failure, they have lipid problems also, and that leads to heart disease. Multiple cancer are now identified as a potential implication due to excessive weight gain in pediatrics and then in adulthood. And it's very clear from the literature that duration of obesity is a very high risk factor. Now we're going to move on to etiology and prevention of pediatric obesity. First of all, I would like to talk about intergenerational cycle. It is known now, based on multiple studies in the literature, that actually when the mother has a weight problem, her child is at high risk for being large for gestational age, and then will become an obese child, an obese adolescent, and then the mother is going to be even at higher risk for her next baby. The one item that I'd like to also highlight here is that the large for gestational age is not the only risk factor. Some obese mothers can also have premature babies, and those will be at much higher risk too. And SGA babies are at higher risk too, especially if they are in an environment where there is a lot of availability of food and lack of exercise. And within 3 years, if they do catch-up growth, they will also be as high risk as the LGA babies. So multiple risk factors. In terms of is this genetic, is this environmental, there is really two phases to this problem. From twin studies that were done way back when, mostly in Scandinavia, where parents of children, of twins, were either taking care of their kids or those kids were in environments where adoption happened, they were able to tease apart what was the genetic component, what was the environment component. And from those studies, we know that around 60 to 80% of the obesity was attributed to genes and family inheritance. There are multiple loci showing that there are multiple proteins that are involved in the regulation of body weight. We're still learning. However, there are a handful of genetic syndromes that we know that are associated with obesity, and on those we really can act very quickly. And we'll talk really briefly at the end of this lecture about that. So it is clear from what we have learned that if a child has risks genetically and they're put in an environment that predisposed to gaining weight, such as sedentarity, lack of activity, and toxic food, if I may call that, in the environment, then you have a major issue with obesity. However, we could prevent this problem if we can act early. And that gives us a chance to talk about the Barker's hypothesis in the next slide, which shows that when there is an environmental problem during intrauterine development, the body is going to try to adapt. And as a result, there will be physiologic changes that probably cannot be changed and adverse consequences down the line in adulthood. Things that have been identified, for example, is that when the mother is undernourished, the hormonal milieu that includes insulin is modified. As a result, we see that pancreatic beta cell in the child is not as efficient, and then there is development of obesity and glucose intolerance and even diabetes down the line. So we have a general framework to explain how conditions in utero may already affect the future of cardiometabolic disease in later life. In terms of maternal factors that are associated with obesity and complication in children, mothers who are overweight, it may be due to weight gain. They also have issues with insulin resistance. They may have had a high dietary intake that led to that weight. And there are multiple changes that are observed in utero, such as placenta dysfunction, hormonal changes, bone and skeletal muscle mass changes, pancreatic changes, liver changes, and also may result in hyperphagia. And so all of this is going to affect the metabolic health of the child who will be born. Once the child is born, the preferred way to feed the child is breastfeeding. And we're learning more and more that exclusive breastfeeding and duration of feeding is inversely correlated with weight gain rates and risk of obesity in children and later in life. The possible mechanisms are multiple. First, we know that there is an increased level of energy and protein in formula feeds, while in breast milk there is less protein, and children who are breastfed are better apt at regulating themselves. Children who are formula fed, it's easy, it's just they swallow it, they don't have to make any effort, and doesn't look like there is a similar satiety component to it. There are, however, some controversies in the literature providing some evidence that there may be a socioeconomic confounding factor. So people who are healthier tend to be breastfeeding more, and this is true in societies like the USA. The other point that may differ between kids who are breastfed versus formula fed is that their bacteria in the gut is different. And so it is very possible that we know there are bifidobacteria are better for you than others, and they may be protective, but more studies are needed. So in the next slide, we are going to talk about the role of protein intake in early years. You may remember that the content of protein in formula is much higher than in breast milk. So there are studies that are currently published, actually very recently, showing that there may be a relationship between protein intake and future obesity. And the mechanisms that are proposed are basically change in hormonal milieu, especially insulin and growth hormone axis. And as a result, you will have early growth in the first 2 years and increased differentiation in your adipose cells. So more on this will be coming in the years to come. Now we would like to talk a little bit about rate of weight gain during infancy. What has been shown in the literature, if you gain weight excessively the first 6 months of life, or in some other studies up to 2 years of life, you will have a risk of obesity that's higher later in life, either in childhood or even in adolescence. There's more and more studies on this. So it is paramount that we try to prevent this early gain, and therefore work and practice in the pediatric office will become more and more important to avert this weight problem. If we shift to adiposity rebound, which is basically a nadir or an inflection point of body mass index percentile between the age of 3 and 7, this can be identified in growth charts looking at BMI. Unfortunately, WHO growth charts are divided up to 2 years of age, 2 to 5, and then 5 to 18 years of age. And thus, it's very difficult to see where this adiposity rebound happened. And since the population is less obese overall, it's very difficult to find. However, with the CDC BMI chart, we are able to see that very clearly because we have data from 2 to 18 years of age or even 20 years of age. And the number of obese patients within the reference, with high weight within the reference is pretty large. And what is very important about this adiposity rebound is that As you go up in percentile, you can already see that the adiposity rebound occurs earlier in life. And therefore, some patients, some kids who have gained weight already in the first 2 years of life will never have an adiposity rebound seen in a chart that's 2 to 5 or 2 to 18 years of age. Those children have been shown in multiple studies across the world to be at even more risk for obesity, diabetes, and heart disease. It looks like a good indicator. However, to be able to look at it, you need the correct growth chart. You need to know how to read them. You need to have them available. And the problem also is a lot of patients go from doctor to doctor. They change location. And so it's very rare when in the pediatric office you will have the ability to identify those cutoff points. Now we're going to talk a little bit about diet and parental feeding practices. Diet quality and quantity is very important as a factor for pediatric obesity. There are many ways that patients will have a high energy intake. I'll take an example that's not here, which is patients who don't take their breakfast. Literature shows that if you skip your breakfast, you're not going to lose weight. At the contrary, you're going to be at higher risk for obesity because you are having all your calories at the end of the day. There are multiple factors such as high consumption of sugar or sweetened beverages such as sodas that have been associated with obesity and higher BMI in the literature in several countries. Other factors are parents who don't understand the cues that are given by their kids. Children may refuse to eat something, and the reason why they don't eat it is that they're full. If the parent doesn't recognize this, and every time the child cries, feed them, what's going to happen is that the cues of the kid are going to be suppressed, and they're going to overeat. Another risk factor, for example, is children who are not breastfed. As we have talked about earlier, breastfed children are less likely to have a weight problem. Parents who are controlling, there are different styles for parenting. Some parents are what we call authoritarian. They're disciplinary. They're the parents who are going to say, you need to empty your plate and eat everything. Those are kids who will not be able to regulate their appetite and will overeat. Children who will do the best are children from parents who are authoritative. And to give you an example, those children have parents who will give them positive reinforcement. So when they do something that's correct, they're going to say that's great. For example, they don't want to eat any more rice, and you can positively reinforce that. The other thing is that some parents use rewards that are food-based, which is a problem. You're going to have a piece of cake if you finish eating. That's not conducive to regulation. And some parents also may use punishments such as which is also conducive of obesity. Emotional eating is a totally different area as a risk factor because it's very psychologically ingrained. You may have children who have had, from underserved area, who have had a very hard life, and the only way they can cope with the loss of parents who have been killed by gunshots, or loss of a grandparent, or an area with trauma will be to eat more because they feel good. It's an instant gratification. So those children are probably not to be cared for in the pediatric office only, but with support from mental health providers. In terms of food intake and other behaviors, in the next slide, we can talk about TV viewing. This is a major problem in our societies, as TV viewing is going to both affect the way you eat and your basic metabolic rate. Children who are in front of the TV have a lower metabolic rate than their peers who are sleeping. The other thing is that children who watch TV are not active. They're not running around playing with other kids. And what's on the TV in between the shows they look? Food. So advertisement is a big culprit here in food intake and more obesity down the line. There also have been quite interesting study that came from Canada that showed that electronic devices in the bedroom are of a big concern. Children who have iPhones, iPads, and other items would have a decrease in their sleep. They are at increased risk for obesity. They have poor quality of diet, and they are less active. So we talked about sedentary behaviors. The opposite of that is physical activity. And it's clear that if you have one, if you increase structural activities, for example, you're going to reduce sedentarity. So the action is not necessarily to say, stop watching TV in the afternoon, but put the kid in an after-school program where they can play soccer. There is a series of recommendations for movement and increased activity for children across their first 18 years of life. And it is clear that parents should be vigilant at modeling and providing guidance so that there is no punishment coming and suppressing those physical activity. So here are some of the examples in the next slide of activities that could be performed by children across their age group. You can see the children who are less than 2 years of age. Obviously, they're going to be really in structural activities. They would be spending time playing, exploring. For kids who are older than such as 4 to 5 years of age or 6 years of age, playing, running, doing things with other kids, going to the playground are things that they can do. Swimming is a great activity too. Swimming is an activity that we like a lot, especially in kids who are overweight and obese, because there is less gravity in the water, but more resistance because you have to fight the water that's around. And so you are really building your muscle and you're not impacting your joints. So very good activity. In older kids, the older they are, the more structural activities are available, and the more you are going to be able to do things within the school setting, after school setting, and organized sports that are more and more structured. Why is sleep more and more entangled with obesity? We are more and more realizing that there is a hormonal basis for this. So people who are, and kids who are not sleeping well, they go to bed late, they're watching their movie, they will be tired when they're waking up in the morning, and they're less likely to want to eat at that time. But they also have a change in the appetite-suppressing hormone called leptin and the appetite-stimulating hormone called ghrelin, which are opposed to each other and result in increased hunger and decreased metabolic rate, and also changes in thermogenesis. And as a result, people who don't sleep well, they feel cold, they want to eat more, they don't feel good, and they're sedentary, they can perform as well, and they will be starting to gain more and more weight. So if you look at the next slide, you have age-appropriated recommendation for sleep. This is complicated to remember. And one way that's easy, I think, to remember is for any kid who is preschooler and up, if they sleep 10 hours, you're good. And for those who are younger, you want to have them sleep 1.5 to 2 times that amount. So this is a very easy way to remember it. So what about dietary prevention strategies? I think that the 2 things to remember in prevention is that you want to give the opportunity to the children to self-regulate so that they're able to read their internal satiety cues. And the other thing is that you want the parent to exercise a style of a parenting style that's going to foster what the child feels rather than forcing the child to do one thing or the other. And again, it goes to auto-regulation. Now we're going to change our discussion to more of a dietary and lifestyle treatment of pediatric obesity. We will start by a case scenario. You have a 13-year-old boy, he just had his birthday yesterday. He's going to the pediatric emergency room with a complaint of being very tired for the past 2 weeks. He cannot participate to sport, and parents are very concerned because there is no social interaction with his peers. This type of scenario might be a possibility in one country. I know in this country, in the US, we would not have a child going to the emergency room for this, maybe for urgent care. When you see the child, you measure his weight, his height, and you plot the child on a WHO growth chart, and you have a BMI of 25.3. And if you plot the child on the growth chart, you see that he's right above the 2 standard deviation cutoff point for his age. You have no history of overweight in the family. The child had been gaining weight and was overweight already in preschool, and then lost some weight, and we don't have information about this, but then started gaining weight again in the last few years. You know that he has no dysmorphic feature, that he doesn't have any decreased central tone, so you don't suspect a genetic syndrome. From a brief discussion with the parents, you're told that they work in a candy factory and they bring all this chocolate at home, and the kid basically feasts on a lot of chocolates and candies and doesn't like vegetables. He spends a lot of time watching TV, doesn't exercise. You know that he may be seeing his cousin, but doesn't really go to the playground. And he works very hard, starting at 10 o'clock at night, because he has been on his iPad for quite a while, and decides to start working at 10, and so he goes to bed after midnight. So this is the case scenario, and I suppose that you are concerned, as I am, that this child has a weight problem and that his behaviors are conducive to weight gain, and that we need to do a further assessment and provide some counseling. So before we go into further assessment and counseling, let's see what are the weight goals for children. So weight goals for different ages are different, and what you would like ultimately is to have the child under a cutoff point of 85th percentile for us in the USA. Depending on the growth chart you use, if it's the IOTF reference, you will use probably the equivalent of a BMI of 25. If you use a WHO, it's going to vary with the age group, because the cutoff point may be 2 or 3 for obesity, depending on age. And you would be talking about Z-scores. So very complicated. So if you have a child who is less than 2 years of age, at least in the US, we don't have any defined target. So that's a group where we feel there's not enough evidence to really provide a guideline. What we do in practice is just make sure that some of the behaviors are modified, parenting skills are aligned with what the recommendations are, and that the weight is stabilized. We do not like to have weight loss in this age group. For children who are 2 to 5 years old, the weight loss, that the goal is about 1 pound a month. For those who are less than 11 years old, we would have similar goal, except for those who are really above the 99 percentile, which is severe obesity, you would like at least 2 pounds per week. And for adolescents, the maximum weight loss would be around 2 pounds per week. Obviously, in real practice, some children lose more, some children lose less, and you need to be sure that you're not in front of an eating disorder problem or a parent who is extremely disciplinary. What are you going to look at when you continue your assessment and you do your physical exam? The way I look at it is I look from the head to the toe. So first, when you look at the face, you want to make sure that there is no eye problems, such as papilledema, which you can identify with your ophthalmoscope. And you will do that if there is a history of headaches. And as you know, typically there is no history of headaches under 5 to 6 years of age. The next thing you can look at is for stretch marks and striae on the body. So you look at the skin. The stretch marks are basically due to your excessive body weight, and you're going to have blanching at the end, while your striae are either you have a cortisol source in your body or you are on steroids, and so you will not see blanching of those stretch marks. You need to look in the mouth and look at the tonsils, because if the tonsils are large, this may be associated with sleep apnea. In terms of neck, you may palpate the thyroid area to see if there is any irregularities. I have to say it's extremely rare, at least in our countries, to see that. Obviously, if you're in an area like sub-Saharan area, you may be in a hypothyroid region, and so that's another story. In terms of your lungs examination, you're going to look for the regular wheezing, because we know that asthma is worsened by obesity, and the amount of drugs that's given is much higher. So weight loss is something that's very useful to decrease medication and improve asthma. You will try to figure out if there is any organomegalia, especially your liver, thinking about fatty liver. You're going to examine your joints and the mobility of your legs and see if there is any limp and leg length discrepancy. One thing that's very often forgotten is flat feet. Patients who have flat feet may have knee problems, and if that's the case, by putting simply an insert through your orthopedic doctor, you're able to have them go and do physical activity. Otherwise, they don't want to do it. So there are a lot of things that are going to happen here from your physical examination that are going to impact your management. Another one is to look at dysmorphic features. So you may look at children who have toes that are webbed, extra toes, and those are very often part of abnormal syndromes. So to continue on our assessment, you have a slide with some genetic syndrome associated with obesity. What I would like to really highlight here is Prader-Willi syndrome, which is a syndrome associated with chromosome 15. One of the issues is that very often the mother in utero will see the baby is not moving much. When the baby is born, is limp, very low APGAR score, Then the first 2 or 3 years of life, very often they need a tube and be fed through the tube. And then suddenly, by 2 or 3 years of life, they have voracious appetite, they can't stop eating, and they become extremely obese. So those are children that you want to identify because they have compulsive eating, they're very difficult to manage, they need a multidisciplinary group, and you can identify them very early on, around 2 or 3 years of age. Another group that's very important to identify is Beetle Syndrome. And one of the reasons is that in this syndrome, you have multiple organs that are touched. You will have the presentation of obesity. You will have abnormal toes, abnormal extra fingers, web toes. But sometimes you don't have those. You will have some retinal damage that will be progressive, and you will also have some kidney problems. But very often you're not aware of the eye, you're not aware of the kidney. And so having a genetic evaluation in kids where there are some dysmorphic feature, it's essential in obesity. And you can catch them up quite early. So the flags for the syndromes are short stature, central tone, and the central tone is very easy to identify. You have a child who is lying down on the bed in your office, and you ask them to sit down from the lying position. And the kid who is fine is going to just sit down. The one who has low central tone is going to squirm and try to help himself get up by using his arms and his hands. So very small tips that are very important in your evaluation. Let's talk about dietary behavior assessment now. Very often folks say that we should use a 24-hour recall, we should use a food frequency. All of those tools are very broad and very, how would I say, not very precise. But they can give you an idea, and they will help you identify areas with the parents to really help with counseling and identifying goals. And what we do in our program is it's very difficult, at least for underserved population, to have a good 24-hour recall. If we ask them what they ate yesterday, very often they say, oh, typically we're not doing that. Okay, so what's typical? So we don't really get a straight 24-hour recall. But we are able to have some ideas if they say, oh, usually this is what I eat for breakfast, this is what I eat for lunch. We'll look at skipping breakfast or skipping lunch. Those are patients who are going to overeat at the end of the day. And so this is a simple intervention that can be done there. The other item is we're going to look through food frequency. We're going to ask them, how many beverages do you have? How much you're drinking in a day? How many glasses? And what we hope is about 8 glasses or 10 glasses a day of 8 ounces or 250 cc's. The children also and the parents will be asked if they eat out or they have takeout. And all those elements are going to help you identify where the problem is and where you can start intervening. So that brings us to the next step, which is, okay, I have identified a problem in the diet of this family. Is the family ready to change? And unfortunately, you may have identified issues, but the parent doesn't want to make the change. Or you may have a parent who undermines the other. You have, for example, a father that works in a pizza shop and he brings pizza at home. So you're not going to be able at the first visit to work on that. What you're going to try is to see if there are other things that you can work with the family. And once the child loses some weight, you'll be able to then introduce the next step, such as the pizza. So how do you assess for readiness? You can, there are certain stages of change that have been identified: pre-contemplation, contemplation, preparation, action, and maintenance. And basically what that tells you is how prepared is the parent to do something about it. So if we look at the algorithm here, you look at what they're thinking. Are you thinking about making lifestyle changes to help your child? If they say no, you know they're not ready at all. And very often, those are patients who are sent to us by pediatricians, and they're scared of the pediatrician, so I'm speaking about specialty clinic. They're scared of the pediatrician, so they come, but they're not going to do anything. So that's a good example of what pre-contemplation is. If they say they want to do something, you ask, are you ready to do something in the next 6 months? If they're not, then you know they're not ready. If they're very likely, you know that they may be either in action change or preparation stage. The action stage is the one where they're going to work with you an agenda, figure out, go and be part of a program, for example, soccer program after school. So those are people who are ready to do things. If they say, oh, but I cannot do that after school because I don't have transportation, I can go, and they find a reason for everything not to be doing, you know, they're not in action stage. But the fact they have talked with you, that they've told you that they're likely to do something, you know that they're not in pre-contemplation or contemplation. So this is important to make changes and counsel the family. So now going to communication counseling tips, once you have this readiness to change, you're able to figure out where the family is and what you can do. It's very important that during the session you are empathic to what the problem are. You want to have, you want to show that you're listening to their problem, and you are going to teach them essentials of healthy eating based on what you have identified as an issue, and you will ask them to monitor themselves. Sometimes it's not possible, but one of them would be to have your goals on the fridge door, and that's a way for them to monitor what they take in and out of the fridge. Or you may have them write in a journal what they have eaten for each of the meals of the day. But that takes time, and a lot of families, at least families we serve, are not going to do this. You also need a high level of literacy to do this. Positive reinforcement, again, is something that's important to be able to have an intervention that's working. And you will be monitoring compliance throughout all follow-up. Having the parent with you, the family, the spouse agreeing to work with you and with the child is important, again, because otherwise you're undermining the effort of the parent. So those are really very brief tips on the approach. So what are the key components for the dietary treatment? You can have an individualization of your treatment. You can keep journals. It's important to have family support. And you need very short-term and very specific goals. Some of the tips are, for example, if you drink enough water before the meal, you're going to be able to displace other high energy intake. So you don't need necessarily to intervene and say, okay, you cannot eat rice. No, you're going to say to them, okay, let's have a glass of water before, let's have a salad before you start your dinner, and let's put a vegetable on the plate next to the rice. And then you haven't told about the rice, but they're not going to eat as much rice because they have been able to fill them up before they start their main meal. Another thing that's very useful is to provide small plates. And why is that? Because we eat with our eyes. If we have a small amount of food on a small plate, it looks like we're eating a lot. If we have the same amount of food in a big plate, it feels like we haven't eaten anything. It's also useful to try to figure out, using your body part, what a portion size is. And this is good for kids who are older. When they are in parties or they are at a friend's house, they're able to then continue with healthier habits in other environments. For infants, the recommendations are a little bit more difficult because we don't have good guidelines. But what we would say is consume a variety of nutritious food. You need to provide milk. If the child has breast milk, great. They will stop when they're full. If you are using formula or how would I say, formula or cow's milk, depending on the age group, you will try to limit the amount that you offer, and typically you will try to stay around 16 ounces during the around 1 year of age, and not more than that. There are new foods that are going to be provided to the child who is between 6 months and 12 months of age, and those foods might take time to be appreciated. It's clear, depending on the literature, you will see articles that say you need to taste the food 10 times or 25 times before you accept it. So it's important to tell the parent that it's going to take many trials before they will appreciate some foods. Very ironically, the kids are going to like the sugary food faster than vegetables. And so one of the things that are recommended is that you introduce the fruits and the vegetables first, so they get used to that before you go to very sugary foods. And we try to stay away from the very sugary foods, but I'm thinking about fruits, for example. So now let's look at what are possible approaches of weight management that are recommended at a systemic level. Here is an example of what the AAP recommends in this country. So the American Pediatric Association. What you will see is that there are 4 stages that are recommended. This was not really, evidence-based. It was more consensus and expert-based. And the idea behind this recommendation were to provide a framework where hospitals who didn't have provider could choose one form of treatment and escalate it if there were other providers further away from their institution. And so the first stage is basically the primary care provider, the pediatrician or the family practitioner, who would be identifying the problem and providing some simple tips. If the child after 6 months was not doing better, they would go to a place where there is a support from a social worker or from a dietitian who would be able to spend a little bit more time and help the physician augment the recommendation. If after 6 months or a year this was not working as well, you would send the kids and the parents to a multidisciplinary team who would approach all the problems at once and provide recommendation. And the last tier would be going to a tertiary care center where now you have access to drugs and to medication and to bariatric surgery. So what you can see is as you escalate the treatment, you increase the type and amount of staff who are involved, and you increase intensity of contact. And we have some evidence for the literature that you need at least 25 hours of contact over a 6 months period to a year period to be able to show improvement. It's not clear the amount that's needed in children who are less than 5 years old. So building on the algorithm we showed in the past slide, the next 3 slides will be providing some details on the approach and the staging of care. The first slide on stage 1, Prevention Plus, basically tells you some tips that have been provided earlier, such as limiting feed intake outside from the home, or, for example, eating daily breakfasts. In terms of stage 2, what that would be doing is to try to increase the amount of counseling based on the data that's gathered, and some of it can be, for example, using structured daily meals and snacks. or adding some lab tests, for example, to identify potential complications. In the level 3, basically this is a very much intense approach. Typically it's done over 8 to 12 weeks, and here you will get tailored information from the mental health provider and the dietitian in addition to the medical doctor. Let's go back to our case scenario and see what we have found on our assessment and what are the recommendations that were done. So based on physical examination, we had a blood pressure that was a little bit high. The child was wheezing, and there was some limited range of motion. And so the weight goals were to try to decrease weight by about 1 pound per week. Obviously, that's not always what's going to happen, but that's your goal. And in terms of diet, we knew that the child had problems with portion sizes and high energy intake from food. And so one of the approaches that were suggested here was to, instead of eating alone, eat a family meal with the parents and include some vegetables, which are going to displace high-calorie foods like rice, and try to limit sugary beverages, since this child was consuming high amounts of sugary beverages. Best is to really provide not only the information as such, but come up with a plan, such as when is the child really drinking those sodas, for example, and try to eliminate maybe 1 or 2 times a week and not try to do everything at once. Therefore, the weight loss might be low at the beginning, but even if you are able to diminish weight gain, that's already a very good achievable goal at the beginning of a relationship with your physician or your dietitian, and that will build the momentum for the follow-up visits. So I would like to conclude this lecture saying that we have seen that childhood obesity was rampant and really a concern, especially for the implication on health that can occur in childhood and in adulthood. We have really pushed on the assessment of pediatric obesity and not just screening for obesity as a key node for intervention. We also know that there are modifiable risk factors such as lifestyle on which we can intervene, and there are prevention strategies that include, for example, feeding practices, physical activity, improving sleep hygiene, and decreasing sedentary behavior. Other key messages are the importance of awareness of the parents of the problem and also their readiness to change, especially if you deal with children who are less than 10 to 12 years of age. After that, it's very important to have the child's readiness to change. The fact that we would like to decrease the BMI below the 85th percentile, but again, in practice, this is going to take quite a while, and you will praise the family even if the weight gain is reduced and there is no weight loss. Pediatrician will play an important role in trying to tackle this problem, and therefore guidelines that will come in the years to come will be very important, and education too. Finally, the American Academy of Pediatrics providing some staged approach to treatment of obesity. This is preliminary, but can provide a framework for practice depending on availability of staff and structure. Thank you very much.